We are trying to see if we can get Dr. Del Rivero virtually with us. Oh, here you are, Dr. Del Rivero. Good to see you. We miss you in Charlotte. But I understand you were on call. Thank you so much for taking out your time. Great talk. We have a room full of wonderful neuroendocrine tumor patients and caregivers. You would be very proud to see we did a good job keeping them engaged. It's almost 4 p.m. And I have my wonderful colleagues, Dr. Mary Maluccio, the creme de la creme of NET surgeons in the US, and my wonderful past colleague, Miss Rachel Miller. She's a powerhouse of nutritional information on NETs. So I'm glad we have a very good panel. We'll go over your questions really fast. If you have more questions, keep coming. Keep them coming, okay? All right. We'll start with, recommendations for which NET specialist group for younger NET patients under 18-year-old. I guess I can take this a little bit. I actually did a combined training in medicine and pediatrics. And the goal was to do a dual, like oncology, adult and adolescent sort of oncology before NETs kind of caught me. It is an unmet need, I would agree. There are not a lot of centers and no even close to what we have for adult NET patients. I don't even think there's anybody dedicated. Dr. Sue Odricio was our sole pediatric NETs champion, and I think she's retired now. That's as far as I know. We had developed a NETs program in Kentucky. I have unfortunately left that, but my colleague, Dr. Sorge, she's a pediatric oncologist, has a lot of interest, actually was part of pediatric NETRP study that led to FDA approval of Lutathera in pediatric population. So she would be somebody who is very comfortable. I recently wrote a review paper on pediatric NETs with an esteemed faculty from Children's Hospital Philadelphia, CHOP. They're very well known, and they also have a very strong NETs program. Not NETs program per se, but a strong oncology program. And that would be another place to go to. St. Jude's is another place that I would recommend. Children's Hospital of Cincinnati is also a good one. But again, there is no bona fide NET specialist. Now, a lot of patients come to me asking me to see them. Unfortunately, have no bandwidth in Miami to see pediatrics, but I have found a colleague, pediatric oncologist, who is passionate, and I think I have motivated her to kind of address to this unmet need. So if you are interested to coming down to Miami, Dr. Aditi Dheer, she's a board-certified pediatric oncologist, has growing interest in pediatric neuroendocrine tumors. That would be another option. So it depends on where in the geography you are. Unfortunately, we don't have a bona fide pediatric NET specialist.
Can I just add to that?
Yes, go ahead.
So I think also what if you read between the lines, is that adult cancer centers are going to be limited in their accreditation to be able to treat kids that are under a certain age. And then you will have kids maybe that become 16 or whatever, and so when they're no longer considered true minors, where they will allow them to be seen. As long as you are in a health system that has a pediatric hospital. So we can deal with pediatric NETs, but that we have to include the oncology component, which is the pediatric center of our health system. So depending on how fragmented the health system is, if it is fragmented into an adult side and then the peds people are like way over here on Mars, then that wouldn't work. You'd have to have almost a separate individual at that site. Indianapolis, though, the whole campus is one campus. So we were able to do pediatric transplant, pediatric neuroendocrine. It didn't matter. It's just that you were doing it as two collaborative efforts. So there are many. University of Iowa was that way, is that the pediatric program was within that. And then obviously Sue Odricio was a pediatrician. And so she ran that component of it. But Iowa also has a pediatric hospital on its same University of Iowa campus.
Great. Thank you so much, Dr. Maluccio.
Can I add?
Yes, Dr. Del Rivero. Go ahead, please.
Yeah, thank you. Just a comment, because we know some of these neuroendocrine tumors may be associated with familial syndromes, such as NCAN. And I don't know if that was something that was discussed today in terms of the familial syndromes. But in those situations, because the familial syndromes are associated with other conditions, and it's usually endocrine conditions, such as the parathyroid glands being activated and causing excess of calcium. So that sometimes can be seen by a pediatric endocrinologist. Sometimes the pediatric endocrinologists are, well versed in seeing patients with that has neuroendocrine tumors, and sometimes having a pediatric endocrinologist who can collaborate with a neuroendocrine tumor expert. I think that's also another suggestion as well that I could recommend.
Great.
Yeah.
Thank you so much. Great comments by everybody. Rachel, next one is for you. What do you think about fasting? We hear a lot about intermittent fasting. You're an advocate of it. Does it help with cancer? And if you do, what type of fasting? 3-day fast, water fast, eating 1 day a meal. And then there's another component for liver tumors, alcohol versus gummies. I don't know what that means, but...
For
You're
what?
saying, what's your preference? Alcohol's a gummy? I go for alcohol. I'm kidding. So, open for interpretation.
Like to unwind? Sorry, that distracted me. What's the first part?
Intermittent fasting.
Oh, yeah.
And how you do it if you have to do it.
It's not a standard, it's not a protocol, intermittent fasting. I know there are some studies that are looking at effectiveness in chemotherapy with intermittent fasting. It can get hairy because, especially if we have blood sugar issues, you can get yourself into some trouble there because we discourage skipping meals, period, with diabetes and glucose control. If you're at risk for calorie deficit, then probably not. But there's not enough evidence for us to say fast with this particular drug and it increases its efficacy, or that it's going to make a major change as it relates to cancer. So, I don't recommend it. I know there's a lot of talk about it with losing weight, shortening the window of time that you are eating and consuming, kind of controlling your calorie intake. But, I don't always know what kind of effect that's going to have on metabolism and health going forward. So no, I don't necessarily recommend it. If somebody wants to try it because it's very important to them and it's not going to cause harm, I wouldn't be doing anything like 72-hour fast or anything like that. Let's not do that. But that's the thing. We talk about what's the risk of that with a patient.
Right.
And alcohol versus gummy. Who wrote that?
I hope they mean the candies. There were some gummies in my basket.
Are you talking about like sugar alcohol and
Are we talking CBD?
gummy bears, CBD,
I was gonna say.
THC? I mean, listen, as long as it's okay with your doctor. I mean, there's more medical marijuana being approved. I think you can get get approval for that in Kentucky. So a lot of patients ask me about that. And some of my patients tell me that they have an improvement in appetite and they eat better, feel better. So
I agree. I mean, it's legal in Florida, so I don't prescribe it, but I don't.
I was going to say, I'm a big fan.
mind if they want.
Although I can honestly tell everyone in this room, I have never tried it in any form. But I think it's really good for people with bony pain related to bone metastases. I think it diminishes the amount of opiates that people need in order to get the same relief. I think for people that have appetite issues, I think it works better than Megace, which is just a synthetic form of an appetite stimulant. And I don't think we have any convincing evidence that it's bad, meaning that within neuroendocrine does cannabis the way it is prescribed. This we do have dispensaries. So New Orleans is just so odd because it was illegal but decriminalized, and you could go to Bourbon Street and just take a whiff of something, and you could probably get more than you would need. But now that they have done it, we have dispensaries all over the place. And so I think that your ability to get it done and prescribed the same way that other medicines are prescribed, and there are physicians, mostly medical oncologists, that have really gotten on board with trying to include that kind of in multimodality treatment. I personally am a big fan.
Well,
Yeah.
and it can be regulated in dosing amount versus just the other way.
Yeah.
Getting it the other
I
way.
don't think it's any longer a taboo thing like it used to be.
Yeah.
And I think there's definitely, I prescribe Marinol quite a bit, which is a synthetic version, and it works very well for a lot of patients. What you have to really, understand is there are a lot of rabbit holes, and people suggest a lot of other benefits which are not their anti-cancer benefits. So just know the noise from the real thing. I think it is beneficial for nausea control, appetite, and those things, and sometimes pain as well. Okay, great. Let's go. I think this is a great question for Dr. Del Rivero. Are there a large number of clinical trials funded by NIH or mostly private labs or private industries? And wondering if any of the trials have been canceled due to changes implemented by the current administration. Wow, we're getting political here.
Exactly. That's a loaded question.
Yeah. What I can say is that studies that has been open, and we still seeing patients. I think seeing patients is not something that has changed. And all the studies that we say open, where they're seeing patients and keep enrolling patients, are still ongoing. So there is no difference in that aspect. Yeah.
Okay.
I don't know if that answered the question, but.
Yes, I concur. So far, so good. All the national studies, and we are part of some of them, are going on. We are cautiously nervous, but so far, so good. We haven't seen any studies being stopped. And to address the other question, majority of studies are done through industry mechanism regardless. But NCI, National Cancer Institute, does support a lot of cooperative group studies. The other set of questions for PRT, I'll have Dr. Maluccio answer the first one. I can take the second one. The first question is, how does collateral damage to healthy liver tissue compare between alpha and beta PRRT agents? And how many times can we retreat with PRRT?
Okay, those are great questions. The answer to the first question is that I don't think that we have any convincing evidence that there's any additional collateral damage with alpha particles. I think we think of it as a slightly more precise, well, I guess it's a better drone and a more precise treatment target. Now, there are definitely systemic side effects, more hair loss, some more fatigue or things like that. They are temporary, and I've had people bounce back. And then when you say the safety of it, so on clinical trials, we have treated patients with 4 doses of an alpha particle, quite potent alpha particle, having already had 4 doses of a beta particle. So we know that you can at least safely do 8 doses of PRRT without having significant differences in the myelodysplastic, the myelosuppression type issues that have been a concern, or we also did not have any significant differences in the kidney related toxicities that were related to either beta or alpha. So I would personally say that our experience, having treated many patients with beta particles and then a moderate number of patients with alpha particles, there is nothing about alpha particles that has concerned me at all. If I were to say, do I need to get a response? Like in this patient, is stable disease just not going to be enough for us? And I had to be able to choose whatever I wanted to off the shelf. I'd prefer an alpha particle because it has a higher objective response rate. But the investment in that response rate is somewhat higher, but I don't think it's because of long-lasting toxicity. It's just around the time, and it's usually by around the 3rd or 4th dose, you're already coming out of it, and we haven't even finished treating you. I don't know what Aman's experience has been. Has that been yours?
Yeah, I completely agree. I think and that's true for both alpha and beta PRRT. I have not seen liver toxicities. I've personally treated close to now 400 patients on standard of care Lutathera, which is beta, since its FDA approval. I've not seen a single case of liver failure post that. Prior to the PRRT era, I did see liver cirrhosis and fibrosis from Y90-based radiation to the liver, and that was a long-term complication. of those type of radiations. In the era of theranostics, we have rarely not seen, and that's the beauty of these theranostics, it's preferentially going to the tumors and trying to bypass a lot of normal liver parenchyma. In fact, there is also a publication suggesting that patients who previously had Y90-based treatments and then some sort of radionuclide-based treatments, at least in the short-term 1-year follow-up, there were no liver toxicity. So far, so good. Now, again, the long-term data from these alpha studies are still awaited. Now, NETTER-1, we have 5 and 7-year published data on those. Erasmus, we have almost 15, 20 years follow-up data. So that's the missing piece when it comes to the novel alpha therapeutics. But so far, I agree with Dr. Maluccio, the early data for responses, that disease shrinkage looks very promising. The long-term safety data is what we need to see. Long-term risk to marrow, long-term risk to bone marrow, kidneys, and the liver.
Okay, can I ask that? Yeah, one thing, because you bring it up. I think that Y90, and Andrew Marsala mentioned it. So when you're using radioembolization, which is just a different particle on the little periodic table of elements that we all forgot about from high school. So, but yttrium-90 directly into the liver is highly effective. But if you're talking about response, it's no more effective than the other two treatments that he described. So for people with somatostatin receptor avid disease, low grade, going to live a long time, I think many of us would prefer that they would just take Y90 out of the equation at all. And I think that Andrew in particular is extraordinarily balanced. So when he's talking about using Y90, he's doing it in higher grade tumors where radiation damage is likely to be more effective, but the PRRT is less likely to be utilized because it doesn't have the same receptor density. So it's not that we don't have a role for yttrium-90 radioembolization in patients with neuroendocrine. It's just that we would prefer not to use them unless there's a serious advantage to them, of which there is not, in patients that would otherwise be amenable to PRRT. And yes, they have shown that it's safe, but there is more long-term data on delayed damage after Y90 in liver-directed therapy than there likely is data on long-term liver toxicity of PRRT. And so it just doesn't have enough of a benefit in low-grade tumors to say that you should be doing that. And I do think that interventional radiologists will gravitate towards it because it's so well tolerated, and you kind of you wake up and it's just really well tolerated. But I think that the risk is just not worth it to me.
Gotcha, 100%. Rachel, next question is for you. Now, we've heard about high amine diets and carcinoid syndrome. Is there a good website which lists the level of amine foods and what is the go-to resource for these things?
Yes.
Or should we just go Google it? These days, ChatGPT is pretty exciting.
It's carcinoid.org, I think it's the Carcinoid Foundation. They have an app as well that you can download and record your symptoms, what you're eating. So that's a reputable source.
Good. Awesome. Okay. Thank you so much for sharing that. Dr. Del Rivero, this one's for you. Your study, the ADC study, the antibody drug conjugate, is it enrolling PNET patients? Can you educate us in like a one-liner? What's that study about? What's the concept, and what's the study population?
Yes. So yes, we are open. We're seeing patients. It's a phase 1 study. So phase 1 is to determine the safety and side effects of the medication, and also to understand what is the maximum dose that the patient can tolerate. Right now, we're going to start at the 4th dose level. So far, we didn't see any side effects on the first 3 dose levels. And just a little bit of background, this is an antibody drug conjugated that targets a specific protein that is expressed in many cancer cells, including neuroendocrine tumors and adrenal tumors. And the protein is called DLK1. So if you ever heard about DLL3, and maybe Dr. Shahan was a little bit about that, it's kind of like within the same pathway, and it's expressed in various tumors. This is a different way to deliver a drug. It's called an antibody drug conjugated, and it has 3 different parts. So the way I explain the patient, it has 3 parts. It has an antibody that targets the protein, the DLK1, but by itself, it doesn't necessarily have the killing effect. So then the biotech company, the pharmaceutical company, were able to manufacture the antibody, but then it has a linker with a payload that is usually chemotherapy. So in order to, and that linker with a payload that is a chemotherapy is going to help to go inside the cancer cells and has this killing effect. So it's a new way now to deliver, chemotherapy drugs or targeted drugs, and that is, used to be used in the past, like years ago, but it has so many side effects. But now they were able to manufacture and make it less toxic to the patient. And like I say, this targets a very specific protein in the surface of the cancer cells that we know is expressed in neuroendocrine tumors and adrenal tumors. So we're including patients with neuroendocrine tumors, neuroendocrine carcinomas, pheochromocytomas and paragangliomas, neuroblastoma, which is considered also a neuroendocrine tumor. Usually that's in pediatrics, happening in pediatrics. We are only enrolling 18 and above right now because we need to determine safety before we can lower the age to 12. Pheochromocytomas and paragangliomas, and also adrenocortical carcinoma, which is another type of adrenal tumors. So we are, I think the hypothesis or the question that we wanted to answer seems very interesting. We're excited about this study. I think the target is also very, very interesting. So we'll see, and it's open. So we can see patients of any cancer type. And
Thank you, Dr. Del Rivero. It's a really interesting study. It's a smart way to deliver chemotherapy just to the tumor, and wishing her all the best. Next one, I think I can take this one. I heard that there is a clinical trial with pills to manage serotonin instead of shots, sandostatin, and lanreotide. Actually presented this data at NANETS last year at national meeting. And the name of study, it's a phase 2 study with the pill called paltusotine. You can get a little bit more data from Crinetics colleague there. So what is this study about? Basically, this pill, paltusotine, is an oral somatostatin analog. Just like lanreotide and sandostatin, which are somatostatin analogs, but they're injectable forms. Some people just don't like needles, including me. So it's good to have another alternative. Now, the study is not testing is better than the injectables or not. All it studied was patients who have carcinoid syndrome, would they benefit from the pill? And what the study found, there was 60% reduction in the carcinoid syndrome symptoms within 2 weeks of starting the pill. So the pill is very effective. It seems to be on par with other form of somatostatin analog. So it's in development. Now, since the phase 2 was successful, a larger international phase 3 study is about to be launched in a lot of places near you. So keep a look out on it. If this is something that you would like to try out, certainly you'll have to be screened appropriately for the study. It's meant for carcinoid syndrome symptom patients, flushing diarrhea patient. But very important study and a good step forward for our CS syndrome patients. In that thought process, there's another question about Zermello. Dr. Malucha, why don't you explain how does Zermello work against diarrhea?
Well, I think you'd be better to. Where's Pam? So Zermello is also a serotonin inhibitor. It's predominantly meant to diminish diarrhea, and I think it is quite effective. So in people where the intestinal manifestations of the disease, it's really a quality of life, not a quantity of life intervention. And I think that one of the only real downsides to it is that sort of depending on how you're covered, it's just really hard to get it approved for all comers. And so even when people can get it and it's effective, even talking to the insurance company and saying, oh, it's so effective, doesn't mean that they say, oh, yeah, well, then we're going to cover it at any greater amount. And so I think that the copay is really variable, but it is effective. And it's predominantly quality of life, intestinal manifestations, control of diarrhea. And I think for many patients, it's a game changer.
I have an interesting anecdote about it. So we were part of the Telestar study. So that was the study that led to the FDA approval of Zermello. So, when me and my mentor, Lowell Anthony, were in clinic, and the FDA notification, FDA sends us the email to everybody when it gets approved. And as soon as we got the email, we had the right patient in the clinic. We were both in the clinic. We arguably wrote the first prescription, and we have a picture of that. It literally, within the minute, we wrote a prescription. So I agree with Dr. Malucha. It's a great drug. It's FDA approved for carcinoid syndrome diarrhea refractory to sandostatin or lanreotide. Okay, so if the shots are not be able to control your diarrhea, this works. It blocks an enzyme called tryptophan hydroxylase. That enzyme converts tryptophan into a precursor of serotonin. So if you block that enzyme, no serotonin, no carcinoid syndrome. That's the logic. Okay, so it works really well. Hey, there's Team Zermello. Okay, shout out to them. All right, great. Let's keep moving. A lot of really good questions, guys. I'm very impressed. What should we do next? Okay, all right. Rachel, that's for you. Are probiotics good for carcinoid control? I'm interested to know that.
Or
too.
what?
Probiotics.
Probiotics, okay.
Over time, should a second biopsy be done? Dr. Del Rivera, why don't you take that one? The second one, biopsy, but start with the probiotics, please.
I think probiotics could be helpful for a number of patients. A lot of times, especially if you're not able to eat a lot of fiber-containing foods that can promote healthy bacteria in your gut, then a probiotic might be something to supplement. So I think it's an individual basis, but that and yogurt with lactobacillus, I think that's a fine idea.
Yeah, I don't think there's any particular data regarding use or, there's benefit or contrary, but in general, it's usually a good thing.
Yeah. And I don't think it's harmful. So if something that might be therapeutic, why not?
Yeah, well, and if I could ask a question for the group, is that I think that we understand a lot more about the intestinal microbiome, like that environment and how it gets sort of fouled up with either different diseases or medications or things like that. So on that note, when would you ever then start evaluating people for bacterial overgrowth because of some of the dysfunction? Because that's a totally different way of treating. So we will usually use something like rifaximin to try to treat bacterial overgrowth. But when we will also use it in probiotics is trying to just repopulate it with all the stuff that's supposed to be there. And so I do think that we get into a tricky thing where we don't really understand the diarrhea or the crampy abdominal pain or things like that. And I think that so many things can get off kilter that I feel like half the time we're like, oh, maybe it wasn't even bacteria, like maybe it's got too much bacteria, and so now we're trying to treat it this way. Like when, at what threshold do you start looking people up for bacterial overgrowth? I think they do have like some stool studies that apparently can do it, and there's even, I think one guy came with a blood test that was saying that he had some enzyme that was markedly elevated. He went on to rifaximin, and it was almost like a deal maker for him, and he had almost tried everything else. And so do you just try probiotics and then dietary and behavior modification, or when would you then have a threshold for maybe saying, hey, maybe it's just a little bit, just completely dysfunctional and I have to work it up?
I guess symptoms and management, because you don't know, but typically we eat the fiber that we eat. When it's broken down, the byproduct is what helps us with that healthy bacteria, but that makes perfect sense that we could see an overgrowth, but how did that happen?
Right.
So I think that's tricky, but
yeah, Dr. Malucha brings a good point. So just to kind of tie this whole thing together. Right? We all hear about diarrhea in NETs patient, right? But let me kind of remind you, not all diarrhea in NETs patients is from carcinoid syndrome. So whenever you have a situation where you have a lot of bowel movements, always remind your oncologist or treating physician to look into other factors. Bacterial overgrowth is one of the commonly unlooked or underdiagnosed thing. Bile acid diarrhea is another one. Somebody who doesn't have gallbladder, they are secreting bile and that irritates and it's a very easy fix. You give cholestyramine, works like magic. right? Shortcut syndrome, diarrhea. So there are a lot of other reasons why patients can have worsening of bowel movements in a carcinoid syndrome patients, okay?
Pancreatic insufficiency.
Pancreatic insufficiency. So that's why you need a whole team. You need a good GI doctor, you need a nutritionist, you need an oncologist, surgeons, all sort of people, okay? All right, so moving on, there's a question about what measures are being developed to make accurate diagnosis earlier. Fact one, over 90% of all NET patients are incorrectly diagnosed and are treated for wrong disease. Dr. Malucha, why don't you take a stab at that one?
You mean
I'm
dealing
giving
with
you
the
all
delay?
the tough ones.
Dealing with the delay in diagnosis. I think that that's just about education. I think in certain parts of the country, if your workforce is born, bred, and raised professionally within that environment, and that they have never seen it and don't understand what it looks like, then you can't expect them. It's not because they are dumb, it's because they are ignorant, and they are ignorant because it was not part of their training. So I would say that surprisingly, since I'm trained at LSU, the residents at LSU could probably pick it out of like 100 people. They'd be like, you got it, because they see so much of it. But then you would go over to Mississippi and they would have been treating it for irritable bowel, gluten intolerance, like every other thing. I've had people that have been on Humira before they would ever have even gotten a diagnosis of carcinoid. It is unfortunate, but that I guess these types of conferences, I think that educating our referral base by like sort of having like lengthy like referral letters that go out and say, hey, these are the types of things you're looking for. We have a referral base that includes primary care and GI and things like that. But that I think we have made some headway, because I think part of the reason why we think that it's going up is not necessarily because there is something in our water that's making it go up. I think they think it's because we're just able to find it because we recognize it more. And I think that probably if we were going to make a big dent in it, it would be with GI. I think you sit in GI for a really long time while they're treating you for everything under the sun. And the second that they say IBS, and because you didn't hit into any other thing, then you usually would say, hey, maybe some blood work or some imaging would be indicated, and an elevated serotonin, whatever, would probably get my attention. But I think most of it is just ignorance.
I agree. I think we have gotten so much better in picking it up. I think one of the unmet need, which I feel, is there are once in a blue moon we find patients who have classic symptoms, but we can't find the disease. None of our scans are picking scopes. It's very frustrating for the patient and to the doctor. We can't help them because we don't know what's going on. I wish we could find a blood test or any other ways for that. Dr. Del Rivero, I have a question for you next. You mentioned that sandostatin can cause hyperglycemia. What's the incidence and what do you do? And I'm also personally interested in what's your NIH protocol, like how frequently you monitor. I monitor HbA1c and lipid panel every 3 to 4 months on my patients. What do you guys do? Maybe I'll learn from you and fix it. By the way, Dr. Del Rivero is also an endocrinologist. She kind of is dual board certified, so she's wonderful. All right, Go ahead, Dr. Del Rivero.
Yes, so there is some information that anywhere from 15 to 50% is the incidence of hyperglycemia, so meaning elevated blood glucose. We usually start seeing that whenever we do blood draws, the acute care panel that includes glucose levels. So we usually start seeing, like, once we start seeing that the blood glucose starts to be in the hundreds, 120, 130, 140, that's when we start keeping an eye on that. And then I usually obtain a hemoglobin A1C, a baseline in all patients with neuroendocrine tumors, but then after that, I repeat it whenever I see that the glucose starts to go high. Because it depends. I mean, at the NIH, we're fortunate to do all blood tests, but sometimes, insurance may approve some or not. And I just want to make sure that, in terms of the hemoglobin A1C, I do the baseline. And then after that, once I start seeing the blood glucose, start to go high, then I start doing, then I request a hemoglobin A1C. And it gives me an idea of whether there is something that needs to be done in terms of treatments for diabetes. or pre-diabetes. And the hemoglobin A1C tells me an average of the blood glucose in a 3-month period. And so that's pretty much what hemoglobin A1C is. And I think I mentioned also on my talk that approximately 4% can cause hypoglycemia. It's very rare, but sometimes it may happen that we can see, low blood glucose because of this. If that happens, I usually have stuck with octreotide, not necessarily with lanreotide. I see more hyperglycemia with lanreotide. But even if that's the case, as long as we recognize it and we treat it, it should be okay, because it's a medication that is needed for many reasons. Why? One is because it helps to control the growth of tumors. The second is because it can also help control the symptoms related to hormone excess. But diabetes is very manageable. It's one of the things that we recognize it, and it's very manageable by any endocrinologists and with the medications that are available. And diet and exercise sometimes can help, and I believe we have a nutritionist as well. But it's one of those things that can be easily managed.
Great, thank you. Dr. Maluccio, the next one's for you. Are pancreatic neuroendocrine tumors in liver different than midgut, or how so? Let me rephrase. Does primary matter, or liver mets are liver mets?
Oh, well, with respect to surgical resection, I think liver mets are liver mets. The grade of the tumor makes it easier or harder to get the tumors out using the enucleation example that I gave you, because we're usually just kind of melon scooping these out of the liver so that we're preserving all of the normal liver function. But the difference between metastatic pancreatic neuroendocrine and metastatic midgut, is very different. The biologic behavior of a metastatic pancreatic neuroendocrine is far less predictable, far more likely to show signs of progression than the same extent of disease if it's a metastatic midgut. I just think that is inherent to the pancreas primary. So when people come and they say, oh, I have a neuroendocrine tumor in my liver, so they took a biopsy out and they said, I have this, they don't know where it is. And so then we'll try to search for it, and 75% of the time it's going to be in the small bowel anyway. But that the category that I probably like the least is going to be a metastatic neuroendocrine of unknown primary, because so much of the decision making we have and the data that supports it, whether or not it's chemo versus PRT or something, often has to do with the primary and not to do with the liver mets. And so we would manage a metastatic pancreatic neuroendocrine differently than we would decision make a metastatic midgut with respect to when we would put chemotherapy on, when we would say what are the results of PRRT. And so if you were to look at pancreatic neuroendocrine tumors with involvement in the liver, we were way more likely to choose PRRT until NET-or-2 came. Way more likely to choose chemotherapy upfront. And now with NET-or-2, now we're just saying, well, maybe we should have been choosing PRRT earlier in the disease. So no liver mets are not necessarily the same from a biologic behavior standpoint, but from a surgical standpoint, it's really more the grade of the tumor that matters.
I agree. Now, I guess because of the PRRT talk, there are a bunch of PRRT-related questions. I'm going to try to consolidate and address them real fast since we're running quite late. Is PRRT indicated for patients with ascites? Ascites is like when the fluid starts developing in the belly from liver mets. And why is the PRRT only approved for GI nets? I'll quickly take that. So I would be concerned if the ascites is from liver mets. If the ascites was from like tumors in the near the intestinal areas, then it's easy. You drain the fluid. You definitely want to drain the fluid. You don't want the drug to be accumulated and radiate there forever. But if the liver mets causing ascites, that is telltale signal that liver is not healthy. That means the liver probably is quite a bit occupied, infected with the tumor. And if there is a very large volume of disease, you have to worry. So one of the things that you need is normal liver function. Bilirubin level needs to be okay. And although we have some very anecdotal data, there was a Mayo Clinic case series, about 10, 15 patients, where they treated patients with PRRT with high volume, high bulk liver disease. But if the liver is kind of started getting decompensated with ascites, you have to worry, because you can really push the patient to liver failure. So again, I think it's difficult to make decision based on just a clinical scenario. You have to be cautious though. And is PRT only approved for GI nets? Why not lung nets? The NETTER-1 study included mid-gut or small bowel patients. However, standard of care use includes all gap nets. For lung nets, it's an unmet need. There is an ongoing clinical trial, NCI-funded trial by Dr. Tom Hope from UCSF. And that study is open in various places. Patients with lung nets can either get randomized to Lutathera versus everolimus. If that study is positive, that will give us more ammunition to advocate for PRRT for lung nets. Having said that, many patients are able to get off-label PRRT if they have somatostatin receptors. And in my experience, has not been an issue in coverage, but it may be. But I always encourage clinical trial participation for lung nets patients. And then quickly about with PRRT platelets, RBCs drop below normal. How long before will we return to normal? Does lanreotide affect the platelets? Again, as a part of different PRT clinical trials, we are obligated to do blood counts. So I know how the blood counts usually look like a week later, 2 weeks later, 4 weeks later, etc. Maybe TMI, too much information. So the reason why standard of care Lutathera is spaced 2 months apart is because once we give radiation, we expect some degree of blood counts to come down, right? But by first month, we already start seeing recovery. By second month, when you're due for your next dose, most patient, majority of patients would have normalized. So when NETTER-1 study was done, you would see 80% patients received all 4 doses per schedule, no problem. However, there are some patients with little bit sensitive bone marrow. They take a little longer to recover. Maybe these are the patients who had prolonged use of prior chemotherapy. So their bone marrow took a lot of beating before. So they take longer to recover. So sometimes I have seen patients need more than 2 months to recover. That's not a rule, that's more a rather rare situation. Even more rare is that there are patients who never recover and they just get 2 doses and we just could not give further dose because their bone marrow could not recover. Could be something in their genes, and we are still trying to learn. Some patients inherently have certain defects that can be exacerbated by radiation exposures, and we are studying them through chip mechanisms, studying their bone marrows. These are the patients maybe high risk for developing MDS or myelodysplastic or bone marrow disorders. But fortunately, this is very rare situation. Majority of patients, I expect the counts recover actually within 2 to 3 weeks. So not too long. So that's sort of a quick wrap up of all PRRT related stuff. Is there continued improvement in amino acid for kidney protection during PRRT? Dr. Del Rivera, you want to start with maybe what is the role of amino acid? And Dr. Malucho can comment on, are there newer amino acids for the PRRT?
I can start, definitely. I'm not a nuclear medicine physician, but based on the studies where we use Lutathera here, the current what the amino acid is given in order to protect the kidneys from radioactive, when the Lutathera sometimes can hurt the kidneys, the amino acids help protect the kidney. In the past, and maybe Aman will know this as well, in the past, we're talking about, I don't know, like 5-7 years ago, there used to be a different type of amino acid that it used to not be as effective as the one that is currently used, and most nuclear medicine physicians are using that. And in my institution, my nuclear medicine physician, Dr. Franklin, likes the current amino acid that is given. And again, so the whole role of this is to protect the kidneys from the radioactive agent because it is eliminated through the kidney in the urine. So that's the main reason. Unless I'm missing something. I don't know, Dr. Sean?
No, thank you, Dr. Del Rivero. And any newer, because you're involved in a lot of alpha, are we doing things differently?
Oh, right, no. And so I think the actual true value of amino acids is unknown, since in many of the European centers, they don't even use amino acids anymore. So I think that the way that we're doing it is because the U.S. is very regulated. And so we're doing it because that's the way it was studied. That was the way it was studied in the U.S. And so we're sort of obligated. If it's not broken, why would we change that? Now, I will tell you that there was a change in the amino acids and how they were compounded within the U.S. because the amino acids used to give you more side effects than the Lutathera. So the current compounding amino acids that the vast majority of us use have not had the same nausea issues that the older version has. So yes, there was a change. I think it was just a concentration issue. I think that the protection is exactly the same. We haven't had any of those side effects, and that we currently, and I doubt that we will change the way that we use amino acids in the U.S. until after we are into alpha particles. And then I think it's going to be Europe telling us when we may or may not need it, and then the FDA may make us do it anyway.
Right. No, I agree. I think we have hit the sweet spot. So if you look at the Lutathera drug insert, you'll be actually surprised that a lot of patients reported bad nausea, bad vomiting. The problem wasn't the drug, it was the amino acid. At that time, because of the supply issues, they had to use what was the currently available amino acid, and it was a multi-amino acid product. And because of its osmolarity, made patients very sick. But when it got FDA approved, I think almost all the centers now use a different formulation. It's just 2 amino acid, and it's very well tolerated. In fact, majority of my patients don't even complain of any nausea, vomiting, and maybe mild, and that it can be very well taken care of with Zofran and something easy. So in the current context, I think we found the right solution for it. And I think we are worried about kidney issues, and that's why we used amino acid to begin with. And we had such a good results with long-term safety data on kidney that why one would say don't break it if it's not broken or something like that, So we like it. The kidneys are not getting hurt. Why change things that are working for us? All right, last question, guys. And this one, wow, you fit in a lot of stuff in there. Okay, so first one for Dr. Del Rivero. Should all patients with NET diagnosis also see an endocrinologist in addition to a NET oncologist?
Well, that's a very good question, and it depends. If there is a neuroendocrine tumor that produces insulin, I think, yes, an endocrinologist will need to be involved because they're very good by managing hypoglycemia and what medications are needed in order to manage the low blood glucose. Some of the side effects of the medication, like diabetes, can certainly be managed by an endocrinologist. They know how to manage and know all the newer medications that may be needed. That said, I do feel like it needs to evolve if there is one, but I don't think like every NET patient needs to see an endocrinologist. And one of the reasons is because endocrinologists are extremely busy, and sometimes they don't have appointments until like 6 months from now, and it's very difficult. It's an issue as well for endocrinologists and somebody who requires attention. I do feel like a NET expert should be able to at least have an understanding of how to manage some of these situations until they're able to see an endocrinologist if needed. In terms of hereditary syndromes like NCAN that has other endocrine conditions, yes, an endocrinologist will certainly need to be involved because of the other aspects related to the MET1 that are not necessarily only neuroendocrine tumors or pancreas or the GI. But yes, endocrinology plays an important role in some of the aspects of the functional neuroendocrine tumor, as well as some of the aspects of the side effects related to some of these medications. Like, for example, I mentioned earlier about there is a medication called the tyrosine kinase, like cabozantin and sunitinib, that can affect the thyroid. So that needs to be seen with endocrinologists. But I don't think that needs to be seen at the beginning. I feel like it's needed when the tumor is functional, when the side effects of the medication.
I completely agree. I don't think everybody needs to see one. Plus, I don't think we have that many endocrinologists. But right patient does need to see one. Second question, very interesting. Probably the answer within the question. I have small bowel primary, liver mets, no pancreatic involvement. However, I have light color, oily bowel movements, diarrhea. which are helped by taking Creon, which are digestive enzymes. If pancreas is fine, why does this happen? Is it from the lanreotide? Dr. Maluccio and Ms. Miller?
No, Rachel can take it because I don't want to bias the whole audience against lanreotide.
What are your thoughts on
absolutely
Creon in patients without any
We
pancreas?
don't, yeah, so we actually don't routinely use Creon. I don't know how, and I got
Not
that.
routinely.
That was from John Dillon from Iowa, where I saw him give a talk exactly like this, and he was using over-the-counter digestive enzymes, and they were working almost better than Creon. So lanreotide, the problem with those drugs is that they will bind to normal pancreas, and so you can get malabsorption. And that malabsorption is likely going to be an acquired phenomena related to that drug. Now, for people with pancreatic neuroendocrine status post-resection, it could also be an acquired thing because we took out some of your exocrine pancreas. What we will usually start with is dietary and behavior modification. So really, malabsorption is about if you eat a whole hamburger and you only got enough juice to break up half a hamburger, then half a hamburger gets down through your intestinal tract underdigested. Your colon's like, what the hell just happened? I have a hamburger. And it's going to put it out your backside underdigested, which is why it tends to go into the fatty, oily matzo ball soup. Flow to this, smells like horrible.
That was a good description.
Yeah.
Yeah.
So I will usually tell people it's really about behavior modification, like you shouldn't have eaten the whole hamburger. So small, frequent meals, trying to not have significantly high carb, high fat meals, which is going to be good for us anyway, and good for all of your loved ones. So I think the dietary and behavior modification is key. And then if that doesn't work, and you're moving into it, I'll usually use over-the-counter. Over-the-counter, like Digest Gold or thing, is that those are going to be what we call sub-pharmaceutical strength, meaning that they do not have the doses of pancreatic enzyme. They are going to have pancreatic enzymes. They are just not the doses that are regulated and therefore prescription strength. But they're also going to have things like the lactase. They're going to have some intestinal enzymes too. And Dylan, who is the diarrhea expert, he said he prefers the over-the-counter because then you don't have some of the side effects of the therapeutic strength Creon and is not nearly as expensive. And so he'll usually go with something that is dietary and behavior modification, followed by then over-the-counter. And then you will literally have people that have exocrine pancreatic insufficiency. We see it on the news now. So EPI is a real thing, and it can cause significant problems with fluid and electrolyte and weight loss. And so absolutely there are patients that require like pancreatic enzyme supplements like Creon. Those are usually going to be the people that are having weight loss related to malabsorption.
I have more patients with pancreatic adenocarcinoma that have more of the pancreatic insufficiency, and us having to cover them with the pancreatic enzyme replacement. But I do have some NET patients that use the Creon, and sometimes we have to change the dose. Sometimes, we usually just start on a middle of the road dose. It is dosed based on weight. And so sometimes we have to up your dose based on if you are eating a hamburger. But yes, a lot of times the smaller, more frequent meals are easier to digest and break down. And sometimes just that high fat concentration, large meal is not helpful. Matzo ball soup.
I agree. I would start with what Dr. Maluccio said, all those changes, but pancreatic insufficiency can happen with these injections, and in my experience, it's dose related. So one of the things for this particular patient, I'll recommend that maybe consider switching lanreotide to sandostatin. There you have some flexibility in dose modification. Lanreotide is one flat dose. So maybe lanreotide is causing pancreatic insufficiency, if that's the reason why you're having all these issues. And there you can optimize sandostatin dose to where your pancreatic insufficiency is not as much and is being well taken by other behavioral modification or over-the-counter digestive. Certainly, Creon is a great enzyme replacement, but it's very expensive sometimes. Last question for the day. It was said PRT can cause myelosuppression, that is bone marrow suppression. And is it contraindicated with family history of myelodysplastic syndrome? So the risk of bone marrow disorder with PRRT, at least the approved version, the lutetium-177 dotatate, is 2%, 1 to 2%. That means if I treat 100 patients, 1 to 2 patients out of those 100 may develop long-term bone marrow risk, may include as leukemia or myelodysplastic syndrome like low blood counts, low platelet counts, etc. So that's the risk in patients with history. Now, if somebody who has family history, theoretically, yes. Could that risk be a little bit higher? Not sure. Would that be an absolute contradiction? Absolutely not. You just have to weigh in what are your options. So I have patients who have history of MDS who have no other treatment option left and their cancer is progressing. I'm not going to worry about risk of something that may happen down the road because the imminent issue is progressive cancer in the liver or some other vital organ. So you really have to counter the risk benefit. I would definitely not discount an important drug like PRRT for not even personal history of MDS, but a family history of MDS. Having said that, I would certainly keep it in contention and I would use my other options before I have to use an option like PRRT or CAPTEM, which can certainly increase your risk of MDS and leukemias. With that, I would like to thank my wonderful panelists, host, and all of you guys for staying back. It was a wonderful Q&A session. Thank you.